All right, well, welcome everyone to our final Radicle Health Summer Lecture. My name is Timothy Byars. I'm the president of Radicle Health and the director of Cannabis Programs at Pacific College of Health and Science. And as always, I'm joined by the Radicle Health CEO and Palliative Care Nurse Practitioner at Stanford Health Care, Eloise Theisen. So this summer lecture series was 8 20-minute lectures. It covered a range of cannabis healthcare and industry topics. We were providing these short lectures on Thursday nights throughout the summer. Part of the reason we wanted to do this was stay engaged with the Radicle community. So if you're, we want to make sure that we stay engaged with you all. So if you're not part of the Radicle community or on our email list, please be sure to join. The community is comprised of advocates and educators and healthcare professionals and cannabis stakeholders. And what we want to do is we want to provide support and information and resources to our members. So for information about how to join, just go to our website. It's radiclehealthcare.com. Click the community link. It's free to sign up. There's no cost to joining or being a member. It just simply adds you to our email list so that you can stay informed about all of our future events. Finally, I want to remind everyone that we have an array of curriculum options at a range of price points for students and working professionals. So whether you are a nurse who is looking for CEUs, or maybe you're helping customers making good product choices, or maybe you're treating patients or advocating for social change, maybe you're just using cannabis yourself, you need evidence-based factual information about cannabis. Radicle Health curricula is up to date, it's comprehensive, and it's informed by clinical experience and expertise and instructional design experience and expertise. So please reach out to us for information about our curriculum that we offer, or click the education link on our website. This presentation is for educational purposes only, and the information presented today is not intended to be a substitute for medical advice. This information is not meant to help in the diagnosis, prognosis, or treatment of any virus, disease, illness, or condition. So today, I think we have an interesting lecture today. It's going to be longer than 20 minutes. I think we're probably going to be pushing the 45-minute to 1 hour mark here. But today we're going to be discussing the putative power couple, THC and CBD. But are they actually a power couple? Or are they an odd couple? Are they two peas in a pod, or are they apples and oranges? Are they thick as thieves, or are they chalk and cheese? This is an excerpt from Project CBD, which I think summarizes the industry's somewhat widely accepted position and a kind of a typical cannabis advocate's position on the combination of THC and CBD. And I'm going to read just one or two sentences here. CBD and THC are the power couple of cannabis therapeutics. Both compounds have remarkable medicinal attributes, and they work better in combination than as isolates. CBD can synergistically enhance THC's anti-inflammatory and pain-killing properties while reducing unwanted side effects. So let's unpack this. First, I think that we can all agree that in isolation, both CBD and THC can produce positive and adverse effects. With that said, the consensus in the industry is that CBD can do the following when it's used in combination with THC. It can mitigate the adverse effects of THC, it could potentiate some of the positive effects of THC, and it can create an entourage effect whereby the combination of THC and CBD produces results that are greater than the effects of using each in isolation. So what we want to do tonight is we want to review some of the pharmacokinetic and pharmacodynamic related interactions that might support or refute these claims, look at some of the studies in the literature to see if there isn't any consensus, and then discuss a little bit of what Eloise is seeing in practice. So let's review quickly some pharmacodynamics, and let's start at CB1. THC is a partial agonist at the CB1 receptor. CBD is a negative allosteric modulator at CB1. So negative allosteric modulators, recall, they bind to a secondary site on the receptor and they decrease agonist binding and they decrease receptor signaling. So they inhibit the agonist. We also know that CBD and THC are promiscuous molecules. They bind at or influence multiple receptor families, that include serotonin, dopamine, glutamate, TRPV, GABA families, among others. So there is a very complex dance that occurs when you consume both of these molecules, and it goes far beyond their influence at the cannabinoid receptors. And the manner in which they interact can vary widely. So for example, we know that CBD and THC can produce pharmacokinetic interactions. So that's when one molecule can affect some process of the absorption, distribution, metabolism, or excretion of a second molecule. CYP2C9 is the primary enzyme responsible for the metabolism of somewhere in the neighborhood of 100 therapeutic drugs, including blood thinners and some non-steroidal anti-inflammatory drugs. This enzyme metabolizes both THC and CBD, but it's the primary enzyme for the metabolism of THC into 11-hydroxy-THC. And research suggests that CBD is a potent inhibitor of the CYP2C9 enzyme. 11-hydroxy is slightly more psychoactive than THC, maybe even a little bit more than slightly. Furthermore, CYP3A4, another enzyme, breaks down 11-hydroxy to 11-carboxy-THC, which is a non-psychoactive compound. So any compound that can influence the CYP2C and CYP3A families can influence the concentration of THC in the bloodstream and the subjective feelings of THC psychoactivity. So CBD's inhibition of CYP3A4 would theoretically allow for 11-hydroxy to remain in the system longer. CBD's inhibition of CYP2C9 might do one of two things. It can decrease the amount of 11-hydroxy-THC. Remember that 2C9 converts THC to 11-hydroxy-THC. And it can increase the amount of THC that is available to the bloodstream, and that THC will remain in the body for a longer period of time. So the effects of these types of enzyme inhibitions, they're likely going to depend on things like the size of the CBD dose, the cannabinoid ratio, the timing of the administration, probably other variables as well. There are also indirect pharmacodynamic interactions that occur between CBD and THC. Now, these indirect pharmacodynamic interactions describes when a molecule modulates a second molecule by binding to a different receptor. So CBD has non-cannabinoid receptor mechanisms that also likely impact the pharmacodynamic effects of THC. So for example, CBD is a potent agonist at the 5-HT1A receptors. These are serotonin receptors. Agonists at these receptors can help relieve anxiety. We also know that CBD can help lower blood pressure. So if an overreaction at the CB1 receptor, so for example, if you've taken too much THC and now you're experiencing anxiety, the activation of 5-HT1A receptors might help mitigate those effects. In fact, the anxiolytic effects of CBD or any substance, whether it's caryophyllene, limonene, linalool, any compound traditionally used to mitigate anxiety, it might be mediated through this type of interaction. There are also direct pharmacodynamic interactions. So we talked about indirect, there are also direct interactions that can occur between CBD and THC. These kinds of interactions occur when a molecule modulates the effects of a second molecule by binding to the same receptor. There are three different categories of direct pharmacodynamic interactions. They're classified as additive, synergistic, or antagonistic. Combinations of THC and CBD seem to operate at the level of all three of these categories. So we have additive interactions. These occur when two molecules act on a receptor in the same manner. So for example, both are agonists. THC and CBD, for example, are both negative allosteric modulators at the 5-HT3A serotonin receptors. Activation of those receptors causes nausea. So when you have THC and CBD and they're both negative allosteric modulators at this receptor site, the effect is cumulative. And this binding might help explain why they're both potent antiemetics. You have synergistic interactions. These occur when a combination of molecules has an effect that's greater than a simple additive or cumulative effect of the contributing molecules. And I would propose that when most people, especially people in the cannabis space, think of entourage effect, they're really thinking of this type of interaction. Chemical compounds in cannabis that work together to produce a synergy of benefits that are greater than the sum of the parts. Shortly, we'll look at a preclinical study that concluded that CBD increased some effects of an ineffective THC dose to the level of an effective one. So they tested both CBD and THC at a certain dose. Neither of them had any effect, and then they put them together, and it had an effect. And then finally, antagonistic interactions can occur when a molecule inhibits the effects of a second molecule. In this category, one molecule might be an agonist at a receptor site, the second molecule might be an antagonist. So they're competing for the same receptor site. You could also have a molecule that's an agonist and a second can be a negative allosteric modulator. Of course, this is the case at CB1, right? We'd mentioned this earlier. THC is a partial agonist at CB1. CBD is a negative allosteric modulator at CB1. So that's a bit of the PK and PD that's happening with combinations of THC and CBD. So let's turn to the literature and review what happens when they're used concurrently in studies. So first, we should note that there's a large body of literature that demonstrates the potential therapeutic effects, benefits of both CBD and THC. This is non-controversial. Furthermore, there's a body of literature looking at using isolates versus whole plant extracts, with mostly the results suggesting that combinations of cannabinoids seem to do a better job. There are exceptions. There's a very good paper by Rousseau, Taming THC, Potential Cannabis Synergy and Phytocannabinoid Terpenoid Entourage Effects. Read that paper if you'd like a comprehensive discussion about that topic. We want to be more specific tonight. We want to look at the effects that we're looking to substantiate. So the suggestions that CBD can mitigate the adverse effects of THC, potentiate the positive effects of THC, and create an entourage effect whereby the combination of those two produce results greater than the effects of using each in isolation. And on this slide, this is the first example. So Rousseau pointed to data that suggested that 10 milligrams of THC typically causes acute psychosis in about 40% of consumers. Now, in clinical trials by GW Pharmaceuticals during the development of Sativex, remember that Sativex is equal parts THC and CBD. They tested 48 milligrams of THC and 48 milligrams of CBD, and they discovered that it produced acute psychosis in only 4 patients out of 250. So that's 1.6%. Now, Rousseau has suggested that this data demonstrates that CBD seems to mitigate the adverse effects of THC. This is a 2010 study published in the British Journal of Pharmacology, which looked at the effects of THC and CBD alone and in combination. This was in an animal model of colitis. This is a study in rats. This preclinical study, this is the one we referred to briefly earlier, this concluded that CBD increased some effects of an effective THC dose to the level of an effective one. So again, this study seems to suggest that it supports the idea that there is an entourage effect where the effect is greater when you combine THC and CBD and then when you use them in isolation. This is a study that seems to support the speculation that CBD helps mitigate the adverse effects of THC. In this study, researchers measured the effects of 3 chemovars with 3 different THC and CBD ratios. There were 159 participants. They were randomly assigned to ad libitum administration of 1 of 3 chemovars. They were assigned either a THC dominant chemovar, so 24% THC, and negligible amount of CBD, no more than 1%. There was also a 1-to-1 ratio with 9% THC, 10% CBD. And then there was a CBD dominant chemovar with 23% CBD, 1% THC. Ad libitum, by the way, means that the participant can use as much cannabis as they wanted, as often as necessary or desired. The researchers assessed the effects of these chemovars in a mobile pharmacology lab before, immediately after, and 1 hour after administration of the assigned chemovar. They measured concentrations of cannabinoids in the plasma, as well as subjective effects, things like euphoria and paranoia, anxiety, and they had a whole list of other criteria. And here's what they found. Participants who used the CBD dominant and the 1-to-1 ratio chemovars had significantly less THC and more CBD plasma in their plasma samples compared to the participants who used the THC dominant chemovar, and no surprises there. The 1-to-1 ratio was associated with similar levels of positive subjective effects, but significantly less paranoia and anxiety as compared to the THC dominant chemovar. This might suggest that the introduction of CBD doesn't impact the positive effects, but does positively impact the adverse effects of THC. I think it's kind of obvious to point out that participants using the 1-to-1 were using a chemovar with less than half the potency of THC. So maybe that was a contributing factor as well. Unfortunately, this is a study that failed to track the milligrams of THC and CBD, and if they did, they didn't publish that data. This was a randomized controlled trial with 177 patients with refractory cancer pain. They were taking very strong opioid doses, about 270 milligrams of morphine, and they wanted to compare that to administrations of combinations of THC and CBD, THC alone, and a placebo, and they tested these patients for 2 weeks. In the THC and CBD group, 38% of the participants noted a pain reduction of 30% or more, versus only 21% in the THC group. There was no difference in adverse events with the combination group versus the THC alone group. The study medication was delivered using a pump action oral mucosal spray. It's Sativex. So they were using either Sativex, which is 2.7 milligrams THC, 2.5 milligrams CBD, or they were using a THC extract with 2.7 milligrams of THC, or they got a placebo. The maximum permitted dose of all the study medication was 8 actuations in any 3-hour period and 48 actuations in a 24-hour period. This study seemed to suggest that combining THC and CBD can improve the efficacy over THC alone. So I think it suggests evidence that CBD can potentiate the positive effects of THC and create an entourage effect. There's plenty of literature also that includes studies. The literature includes studies that came to very different conclusions as well. This is a study published in November of 2022. These researchers wanted to determine if increasing the CBD content of cannabis can reduce the adverse effects of THC. So they had 46 healthy, infrequent cannabis users. They participated in a double-blind randomized controlled trial that included 4 cannabis administration visits. During each of the visits, participants inhaled vaporized cannabis containing 10 milligrams of THC and either no CBD at all, 10 milligrams of CBD, 20 milligrams of CBD, or 30 milligrams of CBD in combination with the THC, and they randomized the order. So after each session, the researchers tested for things like verbal recall, but they also tested for cognitive and subjective, pleasurable, and physiological effects. They measured the serial plasma concentrations of THC and CBD after each session. Their results suggested that at CBD and THC ratios that are really very common in both medicinal and adult use cannabis products, there was no evidence that CBD protects against the acute adverse effects of cannabis. And furthermore, they found that none of the CBD doses had any effect on plasma THC concentrations. So no pharmacokinetic interactions were occurring. CBD was not interfering with metabolism of THC. This is another study published in February of this year in 2023, conducted at Johns Hopkins. 18 healthy adults participated in 3 outpatient sessions during which they ate a low-fat breakfast and then ate 1 of 3 brownies. They either had a 20 milligram of THC brownie that contained no CBD, 20 milligram brownie of THC with 640 milligrams of CBD, or they had a brownie that was just a placebo. And then for the next 12 hours, they were assessed and they provided blood and urine samples at timed intervals. After the participants ingested high doses of both THC and CBD, they reported stronger adverse drug effects, things like anxiety, sedation, memory difficulty. They tested more poorly on cognitive and psychomotor function, and they had greater increases in heart rate than when they ingested the same high dose of THC alone or the placebo. The researchers said that the effects appear to be caused by CBD inhibiting the metabolism of delta-9 THC. And when that happens, it reduces the clearance from the body. It leads to increased adverse effects when compared to the same dose of THC when consumed without CBD. So you might be thinking, aha, it's the super high dose of CBD that's able to influence the metabolism of THC and increase the adverse effects of THC. But unfortunately, it's not quite that simple either. There is some evidence that suggests that CBD can potentiate the effects of THC at low doses also. This is a randomized placebo-controlled trial that examined the acute effects of these compounds alone and in combination when administered by vaporization to both frequent and infrequent cannabis users. This is another small study. It's about 36 participants. And all of these participants were tested with a placebo versus CBD alone, 400 milligrams. And they were tested with THC alone, 8 milligrams. And they compared that with THC combined with a low CBD dose of 4 milligrams or a high CBD dose of 400 milligrams. It's not clear when you read the paper whether they tested for blood concentration, so we don't really have data about whether those doses impact the metabolism or concentration of THC in the blood. They did take observer-rated and self-rated measures of intoxication. And this study suggests that CBD alone showed some intoxicating properties relative to the placebo, which was interesting. Low doses of CBD when combined with THC enhanced, while high doses of CBD reduced the intoxicating effects of THC. So we see the opposite conclusion of the Johns Hopkins study. The enhancement of intoxication by low dose CBD was particularly prominent in infrequent cannabis users and was consistent across both objective and subjective measures. So at this point, I think I'm going to turn it over to Eloise. She's going to talk a little bit about a couple of more studies in the literature and then talk about what she's seeing in clinic.
Thank you, Timothy. I just wanted to highlight a couple slides here that continue to show the exorbitant amount of studies that have been done looking at the role of CBD and THC. And I think, probably many of you right now are scratching your heads thinking, wait a minute, I can't tell, does CBD help lower the adverse effects of THC or does it make it worse? And these are studies going back as far as 1941. And I know the slide that the print is really low, but if you're looking at this slide, you're seeing some animal studies and some human clinical studies. And really what they found in some of these studies, if you want to go to the next slide, Tim, as it got a little bit further on into the 2000s, 2010, one study was showing that higher CBD to THC ratios correlated with a decrease in memory and cognitive deficits related to the THC, and that higher CBD to THC ratios correlated with less psychiatric symptoms common in THC. So that definitely is something that we are seeing consistently in the literature when it comes to CBD and THC together. But again, there are quite a few studies and they tend to be inconclusive. Next slide, please. So again, looking at some of the animal and clinical studies here, we continue to see results in multiple studies with co-administered CBD and THC seems to attenuate the effects of THC, especially with doses of a 6:1, and that's 6 CBD to 1 THC or higher. So the question really comes down to, what ratio matters? And I'm going to talk about that in just a second. If you don't mind going to the next slide. Although this is a really old study, I wanted to highlight the next two studies just a little bit because I want to talk about some case studies that I think this will kind of help set them up. And in this 2004 study, it was looking at CBD and THC compared to THC alone, and found that it provided better pain relief and improvement in sleep. And then the next study was 2010, CBD and THC compared to THC alone actually helped reduce cancer-related pain. And next slide, please. So, my question is, what conclusions can we draw? And I think the answer is what we usually say in healthcare is it depends. So I want to present a couple of case studies. I wanted to make them interactive just to see what you guys think now based on the information that was just presented. Next slide. So we have a 48-year-old woman with insomnia, likely related to menopause, and it's difficulty staying asleep about 4 to 5 nights a week. She's tried Benadryl, trazodone, melatonin, and she's had either little benefit or too many side effects. She complained really of feeling kind of hungover and groggy in the morning. Wanted to try cannabis for sleep. Reports that she's used THC in the past and she experienced paranoia and anxiety. She recently got CBD from a dispensary, which we've determined was a 20-to-1 after reading the label, and reports that she felt nothing. So based on what we have talked about today, would you consider adding in THC to the CBD? Would you just switch her to THC for sleep? Why? Why not? Is anybody wants to, either type in the chat or maybe come off mute and say what you would consider here? There's no right or wrong answer. I can certainly start with what I had done in this situation and what I tend to do. I'm not a huge fan of ratios. I think it can be really confusing and difficult to determine whether or not they're having a response or a reaction when you have multiple, when you have ratios. Of course, we're always going to have variables like terpenes and flavonoids and minor cannabinoids in there. So people are saying they would add in THC. And again, if you look at that study from 2004, it talked about having CBD and THC together actually improved sleep. And these were in some of the pain patients. What would be some of the benefits of adding THC to the CBD? Well, we could see possibly that it's going to be more sedating and she's more likely to get a restful night's sleep. If you just did THC alone, are there things that you would be concerned about? Obviously, with a history of paranoia and anxiety from THC, we did see plenty of evidence to demonstrate that CBD really does reduce some of these psychiatric side effects that people can experience from THC alone. Yeah, so everybody's saying anxiety, the hangover effect in the morning as well can be really effective. So again, you have the opportunity here to customize this person's regimen with cannabinoids at night by having some CBD and a little bit of THC. The other thing is that we do see sometimes, again, the literature is mixed and often inconclusive, but THC alone for sleep, some people will experience a rebound effect where after many years, and maybe even just several months, will take THC, they're falling asleep, sleeping quite well, but suddenly as soon as it wears off and it's been metabolized, they wake up and can't fall back asleep. And adding CBD sometimes can help decrease the chances of that rebound effect. So this is an example where using THC and CBD together might be really beneficial. And she wasn't stimulated by the CBD, but that is something that we might be concerned about, right? Particularly what I've observed in my practice is that women can be more stimulated from CBD than men. And so if they're using it at night for sleep, it might actually keep them up. I'm going to talk about some clinical considerations after this next case study, but just remember this case study for when I bring that up. Next slide, please. So this is a 64-year-old male with chronic pain from osteoarthritis, and he's been using tramadol, 50 milligrams every 6 hours as needed for pain. He wants to get off of it. He went to the dispensary. He was given 10 milligrams of sativa THC gummies to try. I'm not sure that that's what I would have recommended for him.
I can just do some for a few minutes. Oh.
Sorry, that muted me as well, guys. So he took one and felt it helped his pain, but reported it only lasted for 3 hours and his pain came back. Then he tried to take 1.5 gummies, but it was too strong. So in this situation, would you add CBD to his regimen? And if so, what would you hope the benefits would be? And again, this is, you would go with a 1-to-1, okay? Absolutely. Adding some CBD in here based on some of the literature that Tim reported can definitely show that CBD may actually increase the effects of THC over time, right? So he may get more benefit by having CBD in there, longer pain relief. What would some of the other benefits possibly be? Improved pain. Yeah, we may actually be able to help him improve his pain, get off the tramadol faster, also help with inflammation. Absolutely. So there's definitely times where CBD and THC can be really beneficial to put together. And last slide, please, Tim. So the question I always have as a clinician is, do ratios even matter? One of the things that we see a lot in the industry is ratios, right? And again, a lot of that literature that's been done both in animal and human studies over the last, 5 to 6 decades demonstrates that CBD of a 6-to-1 ratio or higher is probably going to be most effective at reducing psychiatric symptoms. But most of the products we see on the market are what? 1-to-1 ratios, 3-to-1 CBD, 21 CBD to THC. So do they matter? When do you consider high CBD and low THC, and vice versa? When do you consider high THC and low CBD? And is a 1-to-1 ratio really the gold standard? How does the information today influence your practice, or how will it change the way that you practice? And will you change how you recommend cannabinoids today based on the evidence that we presented? And you can come off if you want to talk about it or put it in the chat. The one thing, the study that sort of inspired him and I to do this discussion was the John Hopkins study. Was that the one, Tim, where it was 20 milligrams of THC and 600 of CBD?
Yes.
So when that article came out, I thought, okay, I mean, that's great, but it's not going to change how I practice, because most of my patients aren't going to take 20 milligrams of THC, nor can they afford 600 milligrams of CBD. So while the information may be somewhat helpful in practice, it's not practical, right? Again, working with the patients that I work with, mostly older adults, I'm going to recommend maybe 2 to 5 milligrams. And a 20 milligram dose definitely is going to produce a lot of side effects, which I'm trying to avoid. So even if they could afford 600 milligrams of CBD to try to help reduce some of those side effects, I don't even want them to have that much in the first place. All right, so yeah, and I think Jacqueline makes a really good point. We get to individualize the way that patients consume cannabinoids in most states where they have legal access. And it can be really hard sometimes to find the amount of THC that you need, right, Maureen? So we are seeing with some companies, the hemp, where it's 0.3% THC at dry weight, but by the time they produce the products, that THC level can go up anywhere from 2 to 10 milligrams per serving per dose. And those people can now get it over the counter and use it. So access is a little bit better, but we don't know how the revisions to the hemp or agricultural bill will change the way that THC can be put in hemp products. So it's sort of unknown and risky right now for some of these companies. Look at individuals. Do they have a fall risk? What's their income and other meds? I mean, these are really important considerations when, we have evidence right now to demonstrate that cannabinoids are effective for things like sleep, anxiety, and pain. And, I've mentioned in other lectures, And when I'm at Stanford, sometimes I'm not able to offer patients cannabinoids in the same way that I can gabapentin or oxycodone because it's covered by insurance. And that really can be frustrating as a clinician to know that this might be more effective, or they might have less side effects, or it's more in line with what they want, but we're not able to actually get to the place where we can see results because it becomes cost prohibitive for these patients. And Megan makes a great point. I think ratios have the potential to confuse patients. I would just rather see the dose of each cannabinoids. Me too. A lot of times I'm going to, try a THC, and if I feel like they're having side effects, maybe I'll add in CBD, maybe it's CBDA, maybe it's CBG, maybe it's CBN. So I like being sort of an alchemist, right? And being able to put together the combination and cannabinoids I think are best. Do you think ratios are a good medical place for naive medical professionals? Yeah, that's a good question, Jacqueline. I think it allows them some opportunity to recommend cannabis in a way that doesn't feel as scary, right? Because a one-to-one, there's information out there to support that it can be helpful for pain and maybe sleep. But it would be like, me sending somebody to CVS and saying, just get an over-the-counter vitamin D supplement, right? It's the more they know, the more they can actually help the patient. But I think you're right, for the naive or maybe even the hesitant healthcare professional, a one-to-one feels really safe. But then the patient may try it and not have success or have side effects, and then may not actually continue on with cannabis. CBD and THC for agitation with dementia, absolutely. Again, usually with women, we'll start with THC because I find it really effective. Although I'm starting to see CBGs kind of my up and coming favorite cannabinoid right now. It seems to be helping with anxiety. It's helping with sleep. I'm seeing some success with neuropathic pain. It doesn't cause impairment. People tolerate it really well, and it's super easy for them to get over the counter. So CBG is sort of taking over right now for me in a lot of these clinical settings. And it is privilege, Maureen, for a lot of people to be able to afford this. And so, I think the ability to offer more access will happen if it becomes descheduled, rescheduled, and federally legal, so that it either can be covered by insurance or reimbursed through HSAs. And Jennifer says, I think each chemovar does a good job creating the correct ratios, and then regulation so much manipulation during processing, right? We can certainly mess up that plant. And another consideration, if patients are buying separate CBD and THC bottles, is the dosing the same for each bottle? And that's such a great point, because do ratios matter, right? We try to simplify things. Here's a perfect example, right? So, and I love this product. So this is healer.com. And you can't see it because the print's so small, but it says 1-to-1 on here. It's actually CBD to CBDA. So there's also a product out here in California through Papa and Barclays that says 1-to-1. Well, it's 1 CBD to 1 THCA. So it's confusing when you just see these numbers. Patients don't know if the THC is first or the CBD because we don't have any standardization there either. And so, yes, it gets very, very confusing. And if the concentration isn't the same in the bottle, how do you know it's actually a 1-to-1? Right, Caitlin?
Yeah, I would add,
Yeah.
I would just add that, you've got a clinician, especially a naive clinician, who says, go get a 1-to-1. Was it 8 milligrams of THC or is it 20 milligrams of THC?
Right. Yeah. And we've certainly, and again, the Papa and Barclays product is highly concentrated. So each milliliter is like 30 milligrams of, CBD and then THCA. And if that THCA wasn't stored properly, they can have some conversion to THC, and that can be a very impairing dose for some people. And Jacqueline's asking, what about CBN and CBDA and CBGA? Just in general, Jacqueline, or about ratios? So I don't think we're really seeing ratios. I mean, healer.com has the ratio of CBD, CBDA, they do CBGA, CBDA 1:1. I think we'll start to see it a little bit more. And what makes a good point that in some states that number, that first number is representing THC and not CBD. Again, that lack of standardization among the industry is confusing and can often, be the difference between having a mild effect and a very intense psychoactive effect. And in general, I think some of these cannabinoids like CBN, CBDA, CBGA, we don't have great, data on them yet, but from an observational standpoint, I certainly see that CBDA can be great for inflammation and pain. CBN, I'm on the fence about. Often when I see CBN in products here in the California marijuana market, it's like 1 to 5 milligrams. And I'm like, well, is it the THC that's helping the patient sleep really well, or is it the combination of CBN? It's really hard to say.
There are also some dubious practices that companies take when they convert CB or THC into CBN, or even CBD into CBN, so you can get a dirty product, especially if it's in the hemp space.
I think that was my last slide, Tim. I know we have the dude at the end, as always. But any final questions or thoughts or comments or concerns? If you have concerns, tell Tim. If you have compliments, let me know.